So our last lecture session here is going to be on Medicare hospice benefit and how things may change with the healthcare reform. So we've been through the gamut of non-insured patients, Medicaid, Medicare, private insurance. There's also a few other ones that we didn't include yet because I thought it would just make the day way too long. That is military healthcare, VA healthcare, and the concept of private pay, meaning don't take any insurance. It was alluded to in a couple of talks here. But those are areas that also you need to be aware of. It's a little bit different situation in each of those. But right now, Dr. Sanchez Reilly is going to talk to us about the effects on hospice care and end-of-life care. Dr. Reilly.
Can you hear me? Great. So I'm very glad to be here. Now our fourth, right? Awesome. Geriatric Urology Symposium. Dr. Basler, thank you very much for the invitation. I'm going to start from the very beginning, and we're going to be talking about, well, I'm going to tell you what we're going to talk about. We're going to try to outline the Medicare hospice benefit. Why is it the Medicare hospice benefit? It's really a hospice benefit, but Medicare is the major payee, paying about 80% of the total visits or that hospice currently does. So. Okay, we're going to talk about who is eligible for hospice care, and Stephanie is passing around a handout that we will be referring to. I'm hoping that will be helpful and you can carry it on your lab coat pocket or something. And then we're going to define different levels of care, including the Medicare hospice benefit, and we're going to describe the healthcare reform and the specific points that alluded to hospice care. So with that, you probably have talked about this at length throughout the day. Health expenditure in the United States is absolutely crazy. This graphic actually compares us with other developed countries. So if you look at our line, if you can see it in the back, is the red line, and other developed countries are represented by the other colors. That includes France, Germany, Canada, United Kingdom, and Australia. And if you look at this model, you can see that comparing from the year 1980 to approximately, well, the year 2009, our expenditure has been just going crazy, and it doesn't look like it's going down, even with healthcare reform. So absolutely crazy. Not only expenditure is crazy, well, if you compare as well spending on health insurance. So even if you are insured, even if we do have health insurance, which is the main complaint these days, that nobody has health insurance, therefore our health expenses are going up. If you have health insurance, you can see that per capita we're spending roughly $486 as compared to countries such as Denmark or Sweden that are spending $32 or $67. So our system is just not working in terms of in terms of the healthcare expenditures. That's just a little humor. I know you guys are tired, but okay. So not only is expenditure very bad, but also satisfaction with care. All or most of our American people that deals with the healthcare system are not happy. We are very complicated, and so that brings me to the concept to achieve for palliative care. Some of you have seen this graphic before. I'm going to bring this graphic to explain to you what palliative care is, and then bring the hospice benefit into the picture. So at the moment of diagnosis, if you bear with me on your left on your left side, say we diagnose a patient with bladder cancer, and that patient will undergo treatment, and we're hoping that will be a curative treatment. But as the time goes by, and perhaps the treatment was not as curative, or perhaps that patient had other comorbidities, like many of our patients do, you know, CHF, COPD, and end-stage renal disease, then we will be moving into having less and less curative model, and we're hoping that palliative care will be more and more taking over in terms of improving symptoms, making sure that patients plan for the future, families plan for the future, and we're hoping that this will be more comprehensive, not really a disease-directed therapy. So we're not going to treat the bladder cancer, we're going to treat the whole individual, and we're going to make them feel better. until the time comes in which the patient really is terminally ill, and at that point will have to deal with that environment. And this is where hospice actually comes in. So the hospice model comes towards the very end, and a patient has to be terminal in order to be eligible to receive hospice benefits, and we'll talk in length about that. Anybody knows who this is? No idea? Okay. So this lady, her name is Cicely Sanders, and she was a social worker at the beginning of the 20th century in England. And this lady was seeing cancer patients mainly, and knowing that these patients were very unhappy with their services. And so she said, you know what, I'm going to go ahead and become a nurse, because I'm hoping that with this I'll be able to control symptoms once I deal with clinical aspects of it. So she became a nurse, but then she realized that we physicians do not talk to nurses very much. Or if we talk to nurses, is to kind of order them around. Are there any nurses in the room? Okay, good. So, so what happened is that at that time, she decided to become a physician so she could actually make decisions about patient care. So she became a whole interdisciplinary team, a social worker, a nurse, and a physician, and she was the founder of the hospice movement in the world. Dr. Cicely Sanders was the one that first defined the concept of hospice care. And interestingly enough, she also defined the concept of total pain. And what total pain means is that, yes, you do have pain secondary to bladder cancer, or you do have shortness of breath secondary to terminal COPD. However, in addition to having that pain, which is physical, you also can have emotional pain, and that's the pain that comes from isolation, depression, or anxiety secondary to the symptoms the patient is feeling. You can also have a spiritual pain, which has a lot to do with unfinished business, and you can also have so physical, emotional, spiritual, and those are, and social pain, which has a lot to do with practical tasks. So how am I getting to my appointments? Who is going to be, who's going to help me bathing, and stuff like that. So what she said is that, yeah, we all have symptoms, and we're hoping to relieve those symptoms. But in addition to that, if we don't take care of the person as a whole, we will never be able to control those symptoms, and our patients will feel that we are abandoning them and not taking good care of them. So just to summarize, hospice care aims to help terminally ill to live comfortably, and we're focusing on goals of care, not on cure. What does that mean, goals of care? We use it a lot, and our patients tend to ask us, like, well, what is that? Well, I'll give you examples. You know, yesterday I had a patient at a VA who has metastatic lung cancer. He has brain metastases. And his point is he wants to be alive so he can give his daughter away in marriage in 2 weeks. So he's asking me specific questions. Are you going to be able to walk my daughter down the aisle? We will do our best. Yes, we're going to radiate you, and we're going to pump you up with steroids, and we're going to do everything we can to keep the guy functional until this guy actually goes and gives his daughter away, and eventually we know he's going to die. Those are goals of care. What matters to me? Some people will say, as long as I have a pulse, you keep going. That's fine. Some people will say, you know, if my mind goes away, I don't want to be there. Some people will say, I want to be alive until whatever. We have had patients at the VA that have been alive in a ventilator in the intensive care unit for 3 years because their pension was paying for their son's college. So again, those are their goals of care. Is that fair? Well, we're not going to go there, but it's just what each person's main goals and issues are. Now, what I was talking about, well, I was referring to total pain is what the whole person is. So again, whole person care is delivered by a team to the patient as well as the family. So this is what hospice care promises. Now, I want you to remember that hospice care is not equivalent to palliative care. Palliative care is the subspecialty, because now it's a medical subspecialty, that aims to relieve suffering, and is not only for terminally ill patients, but it's also for chronically ill patients. So your patients with severe BPH, the ones that you admit with acute retention, and the ones that all those patients, I bet you that they have some palliative care need, because again, they have some sort of suffering that we can help you with. Now, hospice is a part of palliative care. It's a little piece of palliative care, which is specifically designed to serve terminally ill people. So if somebody has a prognosis of 6 months or less, those patients are eligible to receive hospice services. So very different. Palliative care is more global, and a little part of palliative care is hospice. Now, these are the hallmarks of care. If you looked at our healthcare reform, this is written all over. So we're going to go over them. And it says patient-centered care. So we need to focus on wishes and priorities of those that are being cared for. So again, this goes, what would the patient want? And a lot of our patients come from this culture that, well, you're the doctor, you decide what to do. And so it's really hard for them also to transition. Home and community-based care. So we are hoping that we're able to deliver care at home. Why? It's not only because patient is comfortable, it's because it's cheaper. So why is it cheaper? Well, we're not paying for a bed, we're not paying for their food, we are not, so all we need to do is try to bring the provider home, and everything else is provided for the patient. So it's not only that we're nice and we want to go there, but also it makes sense for our healthcare system. And it's not only home, the house, but also nursing homes, assisted living facility, and other settings. Now, family caregivers, another very important aspect of care. So not only do we need to support the families and teach them how to care for the loved ones at home, but again, it makes sense for our healthcare system. Why? Because we're not paying them. The major part of caregiving in our country is delivered by caregivers. These caregivers, 66%, there was a survey done a few years ago, 66% of them are 65-year-olds or older. 66% are women, of course. 66%, oh, should I know, 33%, excuse me, work full-time. And in addition to that, they provide about 18 hours of caregiving. So in addition to the 40 hours a week or more than they work, they also work the 18 hours for the caregiving. A lot of them are at a very high risk of depression and a risk of sudden death and so forth. But again, this caregiving is provided by a non-healthcare system, which is already very expensive. If we were to pay these people, how much do you think that would cost? Like if we were to pay, you know, grandma's husband or whatever. If we pay them $10 an hour, which is a little bit less than what home health aid will make, we were talking about $450 billion per year. So that's a lot of money. And then interdisciplinary holistic care. So that is delivering care to try to help with symptoms, to try to control pain, and to try to provide a spiritual and psychosocial support. Now, this is the new model, to have interprofessional education, interdisciplinary care, very but also very important. Why? Well, there have been studies that demonstrated that this is cost-effective, increases satisfaction, and improves the model of patient care. So again, unfortunately and currently, the nurses, the chaplains, the social workers are not able to bill for their notes. So they are depending on what we bill. But it's very important, and it saves us a lot of aggravation if we have a team in our clinic. And it also helps the patients with satisfaction with care. Now, systems-based practice. So this is what ACGME has to say. ACGME, you're probably all familiar with this, but this is the organization that accredits our training programs in this country. And what they want us to do is they want us to teach our residents to work effectively in various healthcare delivery settings and systems relevant to their clinical specialties. Not only do they want us to work together, but they also want us to be able to refer to other systems, and that's why I'm here today. They also want to coordinate patient care within the healthcare system. So again, you know, you have a patient, you need a service, you need to know where to refer this patient. We want to incorporate consideration of cost awareness and risk-benefit analysis. So again, this day has been all about this. We want to make sure that you have a cost-effective model. We don't need to order an MRI of every single patient that comes in. We also don't need to refer them to the most aggressive treatment because that may not be the most appropriate model. And also, we want to have a risk-benefit analysis, and this has to do a lot with liability. And we want to advocate for quality patient care and optimal care systems. So not only we want to deliver cost-effective care, but we want the care to be good. And again, it comes. We want to work with interprofessional teams, so we want to make sure that our learners are able to relate to other professionals and work together for the benefit of the patient. So this is the Medicare hospice benefit. The Medicare hospice benefit was established in 1982 by an act called the Tax Equity and Fiscal Responsibility Act. You have to understand that the United States was about 10 years late. When hospice started in the United Kingdom, it took a while for us to get it. But once this was passed, it's been very beneficial. And according to what this act says, it says that it covers all healthcare services related to a terminal diagnosis. That is not true. We're going to talk about it because it doesn't really cover, but it's come a long way since the time it was established. So please remember that date because we're 30 years into it now. Now, what I want you to remember is that Medicare Part A covers all the costs related to a terminal illness. So why do you need to know that as physicians? Because our patients have insurance and we get paid by Medicare. So Medicare A stands for acute, meaning that pays hospitalization. Medicare A also pays for hospice. Now, if you have worked 10 years or more in this country, you have a right to receive Medicare Part A so far. This is about to change, but so far, this is what we've got. Now, Medicare Part B is optional, so when you are 65-year-old, they'll tell you, would you like to receive this super-duper benefit, which allows you to get providers into the system, and they may say yes or no. But Medicare A is a right that we have at this moment. So, therefore, hospice is paid by the Medicare A, so you don't need to pay additional co-payments, or you don't need to sign up for it or anything in order to receive hospice. So every senior citizen in this country, if they have accumulated the weeks enough to receive Social Security, they will have Medicare A. Now, as the other thing that I wanted to talk to you about is that Medicare A covers care unrelated to a terminal illness. So say we have a patient enrolled with metastatic bladder cancer, and that is his terminal diagnosis or her terminal diagnosis. And then patient with this cancer is hit by a car and is cared for the broken leg. So what do? Do we sign him out of hospice and in of hospice, or does hospice pay for the fracture? No. What happens is that Medicare A will take care of the non-terminal diagnosis. Additionally, if you have a patient who has COPD and bladder cancer and is in need of inhalers and oxygen and all that, because the terminal diagnosis was not bladder cancer, the hospice is not going to provide the oxygen and it's not going to provide the medications related to the other illnesses. So again, we just remember that as well, because you say, oh, the patient was referred to hospice and okay, I'll see you. And that is not true, because a lot of the other diagnoses, unfortunately, are not cared for. So eligibility criteria. Patient is eligible for Medicare Part A, so that's, again, Medicare benefit. Now, if they don't have Medicare, Medicaid, which is the insurance for disadvantaged people, also takes care, hospice also is covered by Medicaid. Hospice is not covered by CareLink, except about 3 months ago or so, CareLink negotiated an agreement with 3 hospices in town, which I don't like very much. But those 3 hospices were negotiated by contract. And if the patient is referred by our palliative care team within the university hospital, so they've been hospitalized, they get diagnosed with a terminal illness, and then they don't have anything else but CareLink, those patients will be seen by a hospice, which is better than nothing, because we used to beg for charity. So at the VA, the hospice benefit is covered. So it's fully covered. With every veteran should receive a hospice benefits if that's what they want to do. Other insurances like Blue Cross Blue Shield or other HMOs and PPOs and you name it will also cover for hospice because it's cheaper. Okay. So once a patient is eligible for hospice, a doctor and a hospice medical director both certified that this person has a terminal illness. So say Dr. Basler refers a patient to hospice, he signs a form with his Texas license saying that, you know, I really think that this guy is going to die in 6 months. What happens if he dies in 7 months? Nothing. They have unlimited recertification periods of 60 to 90 days. And we'll see that later, but every couple of months, the medical director certifies this person is still terminally ill. We have had patients for 2 to 3 years, for example, with severe, end-stage dementia. Those are the hardest ones. Those are liver disease are the hardest ones. That you really think they're going to die, they're losing weight, they're not eating, they're more and more functionally limited, and then they keep going. So as long as you feel that this person is terminally ill, you can continue to certify them. The patient elects a hospice benefit by signing a statement, so we really cannot force them upon them, so they have to make sure the patient or the family member need to agree to have this hospice benefit. And then the care needs to be delivered by a Medicare-approved hospice program, and the hospices go to a very thorough certification program. They apply to Medicare. That costs a lot of money in order for them to get certified and to have the appropriate benefits. Interrupt me at any time if you have any questions, because it's probably new information for, yes. Thank you. Yeah, that's a very good point. So hospice, if you are not happy with a hospice agency, which happens sometimes, then you can always fire them and you can get a new one. And you can always disenroll from hospice at any time. We have had patients that, for example, they have cancer and then there's a new therapy that comes up and they want to try more aggressive therapy. In that case, you disenroll from hospice and you go back to your regular care and you can get your therapy. So it goes back and forth. There's no limit on the amount of times you sign up for hospice as long as you meet criteria. So the hospice agency or services, they provide a cadre of team members that are required in order to become Medicare certified, meaning in order to get paid. So they have to have a chaplain, they have to have a social worker, those are full-time positions. They have to have a nurse and they have to have a physician. So that's the core team that they provide. In addition, they have to have volunteers, home health aides, and ancillary members, for example, pharmacists. Some hospices will provide aromatherapists and Reiki therapists and some really fancy things that may distinguish them, and sometimes that's helpful for the patient. So, but it's totally optional. This is the core team and this is what you will get. So if somebody from our family gets enrolled into hospice, and when you are trying to sell the concept of hospice to your patients, you need to understand that the hospice is on call 24 hours a day, 7 days a week. On call means they're not going to be there with the patient all the time. The family member is the one that will provide the care for the patient. So the family member will administer the medications. The family member will provide the cleaning of the patient and all the regular care that a very ill patient needs. But the nurse will be there maybe an hour or so a day, and so will be the aide. For example, they take turns, so they bathe them every 3 days, and they come and dress their wounds and so forth. But if it's routine care, they're not going to be there the whole time. So it's very important that you understand this, because what I've seen when they refer patients to our palliative care team, which we actually control at the VA, we control the referrals to hospice, then the patient and the family member comes, oh yeah, they're gonna be there 24 hours a day. That is not true. They don't provide that, except in very special circumstances, which we'll talk about. So again, hospice and nurse and doctor will provide coverage 24/7. It's really cool because if a patient is in pain or if a patient needs something right away, in a weekend or whatever, there's a pharmacy on call that will deliver medicines, will deliver equipment, will deliver wound care equipment and so forth. So it's really good for the patients, and try to avoid admissions to the hospital. What does it cover? So it covers a one-time consultation to discuss care options, pain and symptom management. This is usually done by the medical director. So the medical director does a home visit, and that person discusses what do they want, how do you want to manage their symptoms, and so forth. All the care related to a terminal illness is covered under this hospice benefit. And the care that is unrelated to the terminal illness will be covered by Medicare Part A. Now, this is the care related to a terminal illness. So physician services and nursing care is provided, medical equipment and supplies, medications to control symptoms, that includes pain. That it bothers me a little bit, these medications, because we send patients with a great regimen from the hospital, and they're well controlled. And when they get to the hospice to try to decrease costs, unfortunately, they change the regimen from something that is a little bit more expensive to something that a little bit less expensive. And sometimes, I mean, we can't really blame them, but that's something you need to think about. Now, at the VA, if you rotate at the VA, don't prescribe narcotics twice. If a patient is enrolled on hospice, the narcotics related to terminal illness are going to be prescribed by the hospice, unless you have negotiated otherwise. We have done it in a couple of times in which, for example, a fentanyl patch is extremely expensive and the hospice is saying, we're not going to cover that. So we will do that. But that is all written all over the chart. So generally, try not to prescribe this twice, because then we get into issues with narcotics. Hospice aid and homemaker services, those are, if they're related to terminal illness, they are provided. Again, they're not going to be there all the time, but they'll provide their service and leave. Physical, occupational therapy, and social work, they'll provide grief and loss counseling. And what that means is that the family is going to be followed 13 months after the death of a loved one. And so how are they follow is very gray, in a gray area. So they could be like a phone call, it could be different grief groups, but they are still follow, which is nice because the family members say they want to be remembered. Other services include short-term inpatient and respite care. So this is really cool because what the benefit says is that a hospice enrolled patient can get 5 days of respite. They don't say how often, but they say several periods of 5 days, so the family can get a break. So that's really cool because, I have had families that take a cruise, they drive to Galveston, take a cruise, and then the patient is dropped off in the unit, and then the hospice cares for them. So it's a great break for the family. And then the inpatient. So inpatient care is a little bit different than the routine care, and that happens when is authorized when a patient has uncontrolled symptoms, when a patient is actively dying, or when a patient is, for example, very agitated and there is a health crisis, really. So the differences between inpatient and the routine care are basically the money. So roughly, a patient on routine care the hospice gets reimbursed about $100 and something per day. And if you go to inpatient care, the hospice gets reimbursed about $500 to $700 per day. So it's much higher if you think about it. But from that amount of money, hospice has to cover nurses aides, the medications, the equipment. So as you can see, they have to be very cost effective. So again, it's a type of system-based practice in which you're trying to save money, but yet you need to be cost effective and patient-centered. And then any other services needed to manage symptoms related to terminal illness. So this is why you hear, for example, how come my patient with metastatic cancer cannot receive radiation? Well, if you refer somebody in the community and that person is on hospice, and hospice is covering the terminal diagnosis, which is the cancer, you are unable to cover radiotherapy with the money that you're paying the hospice. So sometimes they have to opt between radiotherapy and hospice. At the VA, we don't have that problem. We can give them radiotherapy, we can give them chemotherapy. As long as we document it's palliative, we can refer them to hospice as well. And I believe the same in the military. But in the community is different. And this is about to be reviewed by healthcare reform. Services that are not covered. So again, if there is an intent to cure terminal illness, obviously that is not part of the hospice benefit as well as the hospice philosophy. Care from provider that is not arranged by the hospice team. So if they decide to come and for a second opinion, that's not covered. Room and board. So if a patient, very, very frequent at the VA, as well as the university hospital, homeless patient, how do you provide those services? If they don't have an address, and they can't really go under the bridge, so that becomes an issue. And unfortunately, hospice will not provide room and board, so that is not covered. Emergency room care, not covered. Ambulance transportation, unless it's arranged by the hospice team, is not covered. So again, if a patient is in a nursing home and hospice comes, the nursing home gets paid differently than if it was a hospice benefit. Duration of hospice care is intended for 6 months or less, but obviously there are unlimited periods of 60 days in which you get recertified. This is a change as we go into review, because the recertification used to be a piece of paper. So they will fax you a paper, or a medical director will just sign a paper saying, you know what, this person is still eligible. But now, starting on January of this year, the recertification is face-to-face. So now there has to be a physician visit in which you have to go see the patient, review the labs, review everything you got, and then you have to say, well, based on my assessment and the face-to-face visit that I experienced, this person is still terminally ill. So these are the levels of hospice care as we were talking about. The routine home care, that's just the regular care that a person has at home. Continuous home care is if the person wants to stay at home but they have an uncontrolled symptoms, or if they have if they're actively dying, then in that case there is a nurse. 60% of the time it's an LVN or higher, so it could be an LVN or an RN, and there's a nurse taking care of the patient all the time at home, and that is again for very few days until the crisis goes away. Inpatient care also, this is typically done in an inpatient hospice unit. And then respite care, that is the care that the 5 days, as we talked about, that are given to the family so they can have a little break. So routine care is the most frequent and basic level. It is applied to pretty much everybody, and again, the hospice team manages those symptoms. Routine care includes visits by the nurse, social workers, chaplains, home health aid services, the hospice medical director, medications, and then access to staff on call all the time. Continuous care is in home setting, but acute management is provided for a minimum of 8 hours a day. So if the medical director decides that this is what the patient needs, it's going to be at least 8 hours a day. And is mainly nursing care. Obviously, it will be most cost-effective that have a physician sitting with the patient. Is evaluated daily. Inpatient care, as we talked about, is not delivered in the home setting. 24 hours nursing care, and there is a physician that has to visit this person daily. So as if this person was hospitalized. What are some indications of continuous care of inpatient? So severe uncontrolled symptoms, if there's terminal restlessness of agitation, if there's bleeding. We see bleeding a lot with patients that are suffering from cervical cancer, and it's very bad because they just bleed profusely. And sometimes people with esophageal cancer that are vomiting blood all the time is really very nerve-wracking, so they get admitted to the unit. Acute respiratory distress, and again, imminent death, or if they are actively dying. We talked about respite care, so I'm just not going to go through that. Okay, so there is a hospice criteria, so I'm going to just ask you to visit your hospice card, and we'll do it very quickly. Is a laminated handout that you received, or if you have not received, raise your hand and Stephanie will give you one. But basically it has the different diagnoses, very simple to use. The easiest way of referring somebody to hospice is if they have cancer, because obviously the cancer is growing and the treatment is not working well, you have it, it's hospice. But we have other illnesses that are actually terminal, and they have a specific criteria, and we need to consider that. So I just want to invite you to remember that that's very important. For example, COPD. So there are actually blood gases criteria in which you can refer your patient to hospice if they have dyspnea at rest, for example, if they have a saturation of less than a specific number. If you look at end-stage renal disease, so if you have indications for dialysis and your patient doesn't want dialysis, that person can be referred. If you have a patient with dementia and that person is not able to speak more than 7 words a day, that is an indication. If they're not eating, if they're losing weight, if they're having several admissions to the hospital, if, for example, a patient has CHF and is having New York class 3 and 4 symptoms, those are diagnoses that you need to consider. So it's not only your typical cancer patient, but most recently we have been diagnosing referring patients earlier so they can receive the benefit, and we can actually save some money to the system, because believe it or not, palliative care and hospice saves money. So in the interest of time, I'm going to skip the case studies Um, okay. And I'm going to skip this as well. Okay. So in terms of physician reimbursement, so if it's a medical director, the physicians get contracted or are employed by the hospice. Um, just gonna say. And then if it's consulting, so if you were a consulting physician in your particular specialty, the hospice contracts with you, and then the hospice bills Medicare. So you arrange that within the hospice agency. Yes. Well, yes, but for example, we have had lots of cases actually that develop urinary retention, and we are unable to put a Foley catheter. So if that is the case, they have to call a specialist. Or somebody with, give you another example, esophageal cancer who is not stopping bleeding, and is really the family is going crazy with this bleeding all over. So sometimes they have to go and cauterize it, and that procedure is going to be paid by hospice, and hospice will reimburse Medicare. So it's not really all stopped. It's not like we can't do anything else and we just put them in a bed with morphine. That's not the philosophy completely. It's more how do we keep them comfortable. And so we have had patients with malignant pleural effusions in which we have had to refer them to CT surgery to put a pigtail catheter so that can be drained instead of us doing thoracentesis or them dying of shortness of breath. Mm-hmm. Pegs are a little different. We can spend a whole hour talking about pegs, but I'll tell you a story about pegs. So if a peg is going to improve your patient's quality of life and your symptoms, or if you don't have any other way of administering a medication, we have had patients with burning of 80% of their body that cannot swallow, and the only way to administer medication will be through a peg tube. If that patient is enrolled in hospice, that peg will be approved. But if you're going to tell me that you're going to put a peg tube for them to gain weight, for example, in a demented patient, first of all, that doesn't really improve their morbidity and mortality, and second, it doesn't improve their quality of life, and it increases the risk of infections because they pull the tube, and it's not going to decrease the risk of aspiration. So if it's only for that particular reason, that probably wouldn't be approved. But if you're telling me again that there's the PEG is a procedure to improve quality of life because the patient is suffering and there's no other way to administer medications, then that will be a possibility, So it depends on the procedure, you have to make your case. Somebody had a question, yes. Uh-huh. Okay. Yeah, I think I remember that case. Was it at the VA? Yeah. If there was no symptoms, there was no really need to change the stent. But if the patient was happy with the change of the stent and it's the VA, you could do it. If it was in the community, I would say you probably would have a hard time having a hospice covering. But again, at the VA, we have two different piles of money, so we could potentially, we could say that, we could approve that particular expense. The at the VA we have a lot of patients that are receiving radiation and chemotherapy, and they're also receiving hospice. It's very nice to have that done because the hospice can provide relief for symptoms related to the chemotherapy most of the time. So it really depends on where you are. But in the community, I don't think you would have been able to do that. Any other questions? Okay. Okay. So, I don't know if this is interesting to you, but I'm just going to skip really quickly to it. They go by diagnostic codes. I'm sure you are all familiar with CPTs and ICD-9s. The point is that the hospice is the one that has to document all these codes and make sure that they have the correct billing so that can be properly reimbursed. And the most important thing, that they don't get audited for enrolling patients that are not appropriate. So obviously, we always have to have the history examination, medical decision making, and then the documenting with what's going to be the next step. So these are some of the example of codes. I'm just going to move to the new regulations because I think this is the most interesting part of what we're going to learn today. So as you know, in late March of this year, the Congress passed the act called Obamacare, whatever. So anyway, so that healthcare reform is going to change the way that we practice medicine in many instances. I don't know if this is going to change, if elections change the individuals, so we're not going to talk about that, but this stands at this day today. This may change in January of last year. So I went ahead and summarized the different changes that affect hospice and palliative medicine and kind of explain to you how this is going to go, so hoping that this will be understandable. What the government is saying is that we want to have everything being related to productivity. So we want to make sure that there's a lot of cuts on things that are not working or things that are highly billable. So I believe your specialty is going to be greatly affected, particularly by the types of reimbursements that are being done these days, unfortunately. In terms of the hospice, what they've decided is that beginning in the fiscal year 2013, there will be a 0.3% market basket reduction, which means that they, percent per hospice, from fiscal years. So I'm not sure if this is going to take place every year, so it's going to be a 0.3%. Now you will say 0.3% is nothing, but it is a lot of money because hospice is actually work on volume. I mean, you wouldn't make money if you have one patient paying you $100 a day. I mean, that's not going to pay anybody. So, but if you have 500 patients enrolled, then things are different. So, so that's what this is going to be some of an issue, and the hospices are going to want to enroll more and more patients. When I started here in San Antonio, that was 8 years ago, we had 8 hospices. Right now we have 32. So that's crazy. Okay, new regulations of change number 2. After January 1st of 2011, I'm sorry, it was last year, a hospice physician and nurse practitioner must have a face-to-face encounter with his hospice patient. So instead of just saying, oh, you know, that person is terminally ill, I'm just going to sign a document, you have to go to their house, see the patient, document their physical findings, and actually recertify them every 60 days. And the hospice will get dinged if they don't do that. Regulation change number 3. So this is coming up. And so what they say, the Department of Health and Human Services said is that they're going to be demonstration programs. It's a 3-year demonstration program that will allow patients who are eligible hospice care to also receive all other services. So this is what we're heading to. Instead of only receiving either you get your chemotherapy or you get your hospice, these demonstration programs will say, well, we're just going to allow you to receive everything and see if there is any difference in cost mainly. So if you compare, there have been articles that I didn't bring today, but there have been articles that have demonstrated that if you receive palliative care services within the hospital and you compare them with other patients, their savings, again, this is in the hospital, their savings per day are within the range of $5,000 per day, just because you receive palliative care services. So we definitely know how to save money, and this is what the government is saying. Well, if you know to save money, let's just provide more care and see what how the patients feel and if they're happy with the care. So this may stay. So there's going to be 15 hospice programs that are going to be included, and this is going to take place next year. Now, the change number 4 affects children, and what they say, I'm not even familiar with CHIP, but CHIP is the health insurance for children. And this change allows the children to receive both hospice services and curative treatment. Children are very different because they usually have either very aggressive malignancies, which are highly treatable, but they have a lot of symptoms. And they also have malformations and genetic disorders that require a lifetime of care. So we can't limit them, and we can't say that if you live more than 6 months, because also children have very good body, you know, and they're very strong. So so they changed this, which is a good thing. Change number 5. So there's going to be an independent payment advisory board that will represent the healthcare system, I guess, and will be presenting Congress with a comprehensive amount of proposal to reduce excess cost. So what they're going to say is they're going to come to us and say, well, just show me the money, show me programs that will be cost effective. And then they'll have this board, and the board will go to Congress and report to them. So a lot of reporting. I'm not sure if I like that, but other changes, the hospice value-based purchasing and promoting high-value health care. So this provides the Secretary of Health and Human Services the authority to test value-based purchasing programs. And again, this is going to be very soon. So they're going to go to long-term care providers and hospice providers and other healthcare providers. And they're going to say, well, if you have a program that makes sense, that would be cost-effective, we will pay for it. So I don't know if you're all familiar with the PACE programs. PACE stands for Program, help me out, Elizabeth, Acute Care for the Elderly? No. Do what? That's right, Program for All-Inclusive Care for the Elderly, PACE programs, and they're about 20-something in the country, and what they do is they give an amount of money, it's a Medicaid program, and they give, whatever, $1,000, I'm just making it up, but say, $2,000 a month for per person enrolled, and that covers everything, and if that person goes to a nursing home, the PACE program is responsible for the nursing home payment. So the incentive of the PACE program is not to have these patients enroll in the nursing home. So they're going to come up with programs like this to try to avoid costs. And then there is quality reporting. And change number 7 says that it requires hospice on report on quality measures. So, what is the quality of their services? Are they happy? Are the patients happy with their services? Are they having less pain issues? Are they having less disenrollment? Are they having less return to aggressive care, less rehospitalizations? So again, and they will be paid based on the quality indicators. So if the hospice has a score of whatever, which, in the nursing homes, we use different instruments such as the MDS, for example. Here in the hospice, they're going to have specific indicators, and if you have a high score, you'll get better paid. And this is not only going to be for hospices, this is going to be for us, everybody. Change number 8 says that there is a nationwide program for national state background checks on the employees and providers. So they're going to make sure that we are decent and we don't have any past. I don't know what that means, but okay. Change number 9. This authorizes the Institute of Medicine to try to help with symptoms, particularly with pain care management. This started already. The first call for grants was about 6 months ago. And what they want to have is educational interventions to try to educate providers like us and improve our pain management skills. So there's going to be a lot of competitions about establishing training programs. So you don't have to do a fellowship, but you are good at managing symptoms. And this is more, again, education and training programs as well as clinical programs. So there's a lot of regulations to try to improve pain control. So in summary, hospice is a type of system-based practice for terminally ill patients and their families. It has been demonstrated that saves costs, and it is patient-centered care. Specific criteria and benefits are provided. They're very well defined. Healthcare reform aims to decrease costs while providing compassionate care. So hospice and palliative care both are going to be a big part of what the healthcare reform is going to be about. I wanted to finish with giving you some numbers of an article that came out yesterday from the New England Journal of Medicine, comparing the hospice services between 1990 and 2010. And the number of hospice users in 1990, so if you remember, this benefit was established in 1982, were roughly 76,000 patients. Currently, the number of hospice users, this is as per 2010 census, is 1,000,002. So from 76,000 to 1,000,002. The percent of patients who died while cover Medicare who had used hospice. In 1990, there were 5% of the patients, Medicare patients who died on hospice, about 5%. Currently, 44% of patients are dying that are Medicare enrollees. the length of hospice stays hasn't really improved that much, and that's very sad, and I'm hoping to change that from you guys. We started at 25 days, and we're currently at 18 days. So if you refer a person to me, about 18 days later, they will die. And we're really hoping, and at the VA, I think we have done that, I guess because our service is more mature, but we're hoping to have these patients be referred earlier so they can get to know the providers, improve their care, know their goals of care, and so forth. So if you have a patient who you're doubtful about hospice care, just give us a call. We'll be happy to evaluate and hopefully refer them early. We have services at the VA as well as the University Hospital and CTRC, so make sure you call us. Now, this is another interesting number. Percent of hospice users with cancer, with non-cancer diagnosis, excuse me, in 1990, 16%. So those are the patients that we were talking about, COPD, CHF, renal disease. And currently, the percent of hospice users that are non-cancer are 69%. So it has increased a great deal, and again, I'm hoping to continue to increase that because although cancer is very important, a lot of our patients will not die from cancer, although they suffer from cancer. So the total hospice expending obviously has gone up in 1990, 309 million, and in 2010, 13 billion. So lots of money, but I think it's lots of money that we have been able to save from the system. So with that, thank you very much for your attention, and I will take any questions. No questions? Boy, was that boring.